Hello, and welcome to the CAP Today webinar for Thursday, September 16th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host, and I'll moderate a question and answer session after today's formal presentation. Today's webinar is entitled Tuberculosis Testing for Healthcare Providers in the Age of COVID-19. This very important webinar, which combines two such important and now famous infectious diseases in its title, is made possible by a special educational grant from QIAGEN. We want to acknowledge QIAGEN for their help and support, and we want to thank them for their work in helping to get this together for you today at this very important program. Our single speaker, and I'll say more about her in due course, is Dr. Wendy Thanassi, who's with the VA Palo Alto Healthcare System in Palo Alto, California. But before we begin the official presentation, I have a few housekeeping hints. We often recommend that you go ahead and refresh your browser. That may help sync the program well. You have live help available with operators throughout today's webinar. You'll see in the lower right-hand corner of your screen a number, 888-364-8804. So if you have any technical issues with audio or website, they can help you there. In addition, right underneath the slide, you'll see a box labeled Q&A. You can also type in there any technical problems that you have, and they'll be attended to again with the live operators. And of course, the real purpose for the Q&A is for your comments and questions for our speaker today on this topic, and those will form the basis of the session that I'll moderate at the end of the formal presentations. I want you to know we'll be posting all the slides and audio in about a week at captodayonline.com. So you can review this and share it with colleagues. Also, you should know you'll get some follow-up email. I want you to know that. It's all quite legitimate, and it's important that you know that. And finally, of course, let me remind you that CAP Today does not endorse any product or service that may be mentioned in today's webinar. My own remarks are, of course, purely personal, not to be taken as policy of the CAP Today or the College of American Pathologists. And I would like to introduce Dr. Thanassi, but before I do that, I'm going to bring you a message from QIAGEN. QIAGEN is not affiliated with Stanford University School of Medicine. The views expressed herein are those of the speaker and do not necessarily express the views of QIAGEN. QIAGEN would like to thank our speaker, Dr. Wendy Thanassi, for her presentation. QuantiFERON TB Gold Plus, QFT Plus, is an in vitro diagnostic aid for detection of Mycobacterium tuberculosis infection. QFT Plus is an indirect test for M. tuberculosis infection, including disease, and is intended for use in conjunction with risk assessment, radiography, and other medical and diagnostic valuations. QuantiFERON TB Gold Plus blood collection tubes by QIAGEN are by QIAGEN, or QIAGEN product. The liaison analyzer is a DiaSorin product. For up-to-date licensing information and product-specific disclaimers, see the respective QIAGEN kit instructions for use or user operator manual. The QIAGEN instructions for use and user manuals are available at QIAGEN.com or can be requested from QIAGEN Technical Services or indeed from your local distributor who has contact with QIAGEN. And now let me introduce Dr. Wendy Thanassi. She's the Chief of Occupational Health at the VA Palo Alto Healthcare System in Palo Alto, California. She trained at Stanford and is board certified in emergency medicine. She's also a medical review officer, as you see there, MRO, and her master's that we are talking about and presenting comes from her work in international economics. So you can see that she's a very well-educated and very well-qualified speaker, and we're looking forward to her presentation today. I'll ask her to begin in just a moment, but first, could I have the first polling question? And these are a couple of questions just to get your juices flowing before the presentation. Is your organization still requiring annual TB testing for employees? You have yes, only patient-facing, or no, they're no longer having annual TB testing. Please go ahead and vote. Okay, well, that's an interesting result. We'll go ahead and close that poll and put up a second question for you right now. And that is as following: is your organization moving towards contactless protocols wherever they can? And you can see the vote there is pretty overwhelming in this new era. Thank you for your response, and thank you for your feedback. And with that, we'll take the poll down. And now it's my pleasure to welcome Dr. Wendy Thanassi, who will begin her presentation now. Dr. Thanassi.
Well, good morning, everybody. Thank you for spending your time with me today. I really appreciate the invitation from your organization, TAP, and I'm just very grateful to be able to spend this next hour with you talking about something near and dear to my heart, which is tuberculosis, particularly the testing, because it is what you do in the laboratory, what we do as practitioners ordering these tests, that's going to be our way forward toward elimination in the United States. So I'll run through some objectives that we've got today, and I'll look forward to questions at the end. I'd like to present a little bit of sort of a story of tuberculosis. So we're going to start with right now and what's happening with the COVID-19 pandemic, its influence on tuberculosis globally, and because, of course, that affects what's happening in the United States. We'll review the U.S. public health data, particularly in regards to healthcare workers. And for the many of you who work in laboratories, I know that you spend a lot of your time doing the annual testing of healthcare workers. And I just saw on the poll that it looks like there's still about 40% of the group that's listening right now that's doing annual testing, about another 10 or 15 that are doing somewhat less than annual, maybe some specific groups. And I really want to address that because that testing of the healthcare worker has been a driver of policy in the U.S., and there have been some recent changes. And what I'd really like to go through with you using the data is why those changes were made and how the changes that came out of these laboratory results drove the policy. So the next little section is about healthcare policy guidelines for testing and treatment. And at the very end, we'll talk a bit about IGRA roles, well, hopefully a little bit more, and LTBI treatment in these times when everything is so challenging to us. So thank you again for your time. Moving forward, I used this T-shirt because it struck me earlier in the year. It said, "Science, it's like magic, but real." And that's the way I look at it. Okay, let's talk about COVID-19 and tuberculosis a bit. So you all, I think, are very TB savvy, and you probably realize that TB has been the leading cause of infectious disease death in the world year after year after year. And in fact, it was the leading cause of infectious disease death in the United States 100 years ago. So around 1915 to 1920, it was still the leading cause. Actually, it was the leading cause of all-cause death in the United States. But we are now 100 years later, and that's obviously not the case in the U.S. anymore. We'll talk about that. But in 2020, COVID-19 mortality overtook TB as the leading cause of infectious disease death in the world. In fact, so in the world, over 200 people have, in the world, over 2 billion people have latent tuberculosis, with about 5 to 10% lifetime becoming active. That means there's over 10 million people a year getting active tuberculosis, right? The part that, causes lung destruction and eventually the disease called consumption, where the metabolic rate required to support this growth of the Mycobacterium tuberculosis causes people to be unable to keep up nutritionally with what their body needs to reproduce this infection. And that results in a 10 to 15% mortality in those people who get active TB. That's huge. We're having 1.4 to 1.8 million people every year die of TB. And the reason I bring that up is that we saw 1.8 million people die of COVID-19 in the year 2020. So for over 100 years, and then we can look back thousands of years at tuberculosis, but since it was the leading cause of death in 1915 to 100 years later now, we have had a TB mortality in the world that far outstrips anything we've ever seen in any other infectious diseases. So there's some debate about malaria. I'll do a shout out here to Bob McGonnagle. So 1.4 million people dying every single year of tuberculosis, every single year. And last year, one time, a 1.8 million person death. I'm not minimizing these horrible deaths from COVID-19, but I do want to put in perspective how many people die of TB every year. And to go back to malaria, that number is about 400,000 a year, so about a third at this point. This year, in 2021, we've already seen 1.8 million deaths from COVID-19. Some of this is going to reflect increased testing, but I would argue that in tuberculosis, the testing is far inadequate also, and the number of people dying of TB is much higher than actually recorded, as is the number of people dying now of COVID-19. So they are both terrible scourges. They're both pulmonary diseases. And so we're going to see a lot of impact from this infection in the future and the future of tuberculosis. We're doing a good job, that said, worldwide, with over 60 million lives being saved from TB global health efforts since 2000. But it's still not dropping the rates fast enough. So let's look at this slide really quickly. I'm sorry it might be a little bit blurry. On the left, what you'll see is that following quarantine, the additional estimated deaths from tuberculosis are about 6.3 million over the next 5 years. The number of cases of TB worldwide are felt to be an increase in about 6.3 million cases worldwide from where it would have been if we had continued our downward trend without COVID-19, and the additional deaths from tuberculosis are estimated to be over 1.4 million in the next 5 years. Now, looking not at just tuberculosis, but at the second half of the slide on the right, you have a hazard risk and an adjusted hazard risk, which shows that people who get COVID-19 and also have concurrent tuberculosis are 2.7 times more likely to die, and if they have concurrent HIV with COVID-19 are over twice as likely to die. So you've got it both ways. You've got it sort of in both directions. So TB that then gets COVID and COVID that then gets TB. And let's look at this worldwide. So I really like this graphic. So the vertical lines on the left and the number on the y-axis tells you the incidence rate of cases per 100,000 population per country, which is lined up on the x-axis. Now, I did this chart a number of years ago, and you can't fit all the countries on the x-axis. In between each of those vertical lines are other nations. Whole countries, Cambodia, Zambia, way up there in the upper left, showing what a scourge tuberculosis is in those countries. To the far right of the graphic, you'll see a bright red line that looks like it's over the United States. That goes up to the number 90, and that's the average worldwide incidence of tuberculosis on the globe, 90 per 100,000. But what's the United States doing over there on the far right? Well, you see that it can't even mount a vertical line. Our TB incidence in the United States, this giant, beautiful, diverse country of ours, has such a low tuberculosis incidence rate as to keep company with Monaco, Iceland, the British Virgin Islands, Grenada. Those are the countries that we keep company with in terms of having essentially no tuberculosis. Now, you've all seen TB tests that are positive, but I want us to be really careful when we talk about TB in the United States to understand that we are nowhere near what the rest of the world is facing. In fact, the United States carries 0.00005% of the global tuberculosis burden. And it used to be that we were terrible donors to international efforts, and we've made good progress as a country, so that now the U.S. is funding the global TB efforts at over $330 million, which 20 years ago was only $64 million. So that's good citizenship in the world. And we are now the largest donor to the Global Fund to fight AIDS, TB, and malaria. All right, moving forward. So then, if we've got so little TB, how do we quantify that? It's very hard to do, actually. And nearly 10 years ago, we finally got a study out that used the quantiferon, you're all familiar with it, the test made by QIAGEN, the interferon gamma release assay. And that blood test should be much more accurate than the old studies, which were the NHANES study, NHANES, that used TST, the skin test. So the estimate for the United States for latent TB was about 14 million 10 years ago, or 9 years ago. It was about 9 million when one did studies just using estimates and assumptions, and that was in 2015. And then when we look at what is the cost of treatment in the United States, so we move from latent tuberculosis to active TB and say, well, what's the impact of these numbers? Well, if you're going to spend $172 million as a nation just to treat active TB, and we only donate double than that, $334 million, which is interesting. It's like exactly double. To the global TB relief effort, you see that we're wasting an extraordinary amount of money treating active TB when we should be focusing on latent TB and diagnosing that and treating that. So the United Nations, World Health, and CDC, their goal to eradicate TB by 2030 is going to require that we identify where are those people, who are those people who have latent TB so that they will benefit from treatment. So that said, if our big, beautiful nation has so little TB, there must be pockets of where it lives. So where it lives is these 4 states. They make up 52% of all of the cases in the U.S. That's New York, Florida, Texas, and California. That is not on a per capita basis. That's on a purely case basis. And why is that? Essentially, these are our border states, right? So New York is getting a huge amount of immigration, as is Florida, Texas, and California. It's our southern border with Mexico that's bringing most of the TB in, and then also with California's proximity to the Pacific Islands. And the reason I bring that up is when you look at per capita or incidence of tuberculosis compared to population size, the highest incidences are actually Alaska and Hawaii, as well as California. Now, why is that? Why Alaska and Hawaii for having so much TB? Well, Alaska is actually really interesting. I went to a great conference in Canada about that once. They have a Native American population, formerly called Eskimos, who are very nomadic and living way up in these isolated regions in northern Alaska, staying indoors for many months of the year in close, tight quarters with indoor kerosene and other types of sort of pulmonary toxic heating methods. They're very hard to reach by the public health workers. People can't get out there and find them. They can't follow up with them to do treatment for a long time. So Alaska has been, and it also has a great proximity to the Pacific Islands, Alaska has been a real challenge for TB elimination. Hawaii is the Pacific Islands population. Philippines has the 9th largest TB rate in the world. And we get a lot of people in those states from there. I just thought you'd find that really interesting because those of you who are joining us who are not in those 4 states can also rest assured that you would be so far off the right end of that graph there as to be unlikely to see much tuberculosis in your lifetimes, I hope. Here's another chart that just shows what I was talking about, which is that the biggest incidence is in the Native Americans, the Pacific Islanders, and other Asian demographics, obviously Mexico as well. And that also means that about 72% of people who have latent TB were born outside the United States. So you add these states with people who are born outside of the U.S., and you start to see what population it is that we really should be testing. And let's argue that maybe that should not be healthcare workers. Let's move forward. So we were making great progress in eliminating TB in the U.S. We were going down steadily every year, 3.4%, 3.2%, 3%, down, down, down. And then in the late 80s and early 90s, there was an upward blip in elimination. And if you were a live audience, I'd ask you what you think that is. But instead, I'll tell you, why did we go backwards in our TB elimination efforts in these few years? It was because of HIV. And the reason I bring that up is we're going to see the same thing with COVID-19. So all of the public health efforts were distracted and moved toward this other terrible scourge that was affecting so many of our citizens, including a lot right here by the San Francisco Bay. And diagnostics on tuberculosis declined, treatment declined, and we saw very rapidly the rates of TB go up in the U.S. So if you look on the far right-hand side, getting toward 2020, I would anticipate that we're going to see an upward blip again. And we see some evidence of that from our colleagues in the National TB Controllers Association in coordination with the CDC in a paper they presented in mid-2020. So the COVID-19 scourge was recent, and they showed that 90% of TB programs had deployed their personnel to the COVID-19 response, and 60 to 72% of all public health TB efforts in the United States that the National TB Controllers run the TB arms of public health, they had experienced partial or high impact on their staffing. And then we also know that U.S. TB diagnoses went way down since COVID started. So if all of the personnel like me who did TB full-time switched to really full-time COVID-19, one can anticipate that it becomes again sort of a crying child in the corner who nobody's paying attention to. I guess that's a little the way I see it. So another good paper I'd really like you to see out of San Francisco. So also, this was published in the MMWR. If you look at the graphic on the right, you see a steady decline in tuberculosis over time, and then you see a steep drop. Let me see if my little circles work. Not quite. A steep drop on the far right-hand side between 2019 and 2020 for TB diagnoses. Well, or TB cases in this case. So why is there that steep drop-off? Normally I would drop these reasons in one at a time, but either we weren't making as many diagnoses, which we talked about, or there were real reasons that TB dropped off. We had a real block on immigration for a few years, and we talked about TB being in the foreign-born. So did our decreased immigration mean that we actually brought in less TB than we had in years before? Was it because there was actually decreased transmission because everybody was using PPE and staying indoors and staying separated? Was it because of decreased diagnosis, or was it all of the above? And I sort of suspect it was all of the above. So I'll be interested to see how this plays out over time. But we do know that there was a dramatic drop in diagnosis. Well, this paper that just came out is worrisome in terms of going toward answering that question. So this paper published in EID, a paper I really like, is out of San Francisco. And the figure here, which is kind of complicated, I have some circles sometimes, but where you see a steep drop-off in the middle of the slide toward 2020 is the decreased hospitalizations and mortality from tuberculosis just after SIP, which they've labeled, which is shelter in place. So studying hospitals in San Francisco, California, they see a decrease in the number of TB case patients receiving treatment by month. And their report is that in the first few months after the pandemic, numbers of patients newly diagnosed with TB decreased compared to the year and a half prior or the year plus prior. And then by early July 2020, so just 6 months into the pandemic, the number of patients newly diagnosed with TB did begin to increase. And now a higher proportion of them required hospitalization and had TB-related death. This goes back to that slide I showed you with the HIV. These people are like canary in the coal mine here in San Francisco. We are seeing an increased number of hospitalizations and deaths from tuberculosis because we were not seeing diagnosis and treatment of LTBI. We're also seeing late recognition of tuberculosis because it looks like COVID, right? You've got a pulmonary disease. So let's move forward now to what was happening with healthcare personnel. The number of active TB cases in the United States in 2016, and I can't get more recent data than this because this study hasn't been redone by the CDC. But when they looked at TB diagnosis by job type, and I just pulled out healthcare personnel, of those 8,600 active cases of TB, only 3.4% of them were in healthcare workers. Well, why does that matter to me so much? Because that means 96.6% of tuberculosis in the United States was not in healthcare workers. 96.6% is not in healthcare workers. I'm talking to you, the 44% who said you're still doing annual TB testing. Perk up, because this is how I want you to go back to your leadership and be able to argue the science against doing annual TB testing, but rather focus on the right populations. If 96.6% of active TB in the United States is not in healthcare workers, why are we testing up to 20 million a year? So 18 million U.S. healthcare workers a year are in the United States, and then you spread that out. You've all been experienced with your basketball coach and your babysitter and your school nurse and your teacher all needing to do TB testing because there's this trickle down from this sense that it's somehow lurking out there as a secret infection. But it's not. We know where it is, and I've shown you some of those graphics before. Let's look again at healthcare workers in case you want a little more data. And this graphic is in a paper that I first authored that I'll show you later. I tried to make really simple graphics that people could pull out and stick over their desk or use in the discussions with their leadership. As I talked to Bob about, economics discussions are good drivers of policy. So when we look at the incidence of tuberculosis in healthcare workers between 2003 and 2007, we see that it was lower than in the general population. And when we take another time frame from 2010 to 2016 using different papers, we see that the incidence of tuberculosis in healthcare workers is again below that of the U.S. overall general population. And why does this make sense? So this makes complete sense, complete and total sense to me. Who's a healthcare worker? Who are we? We are in the prime of our lives, or some of us like post-prime, but kind of prime-ish. So that means we're in our sort of 20s to 60s-ish. We're not babies. We're not the elderly. We also tend, as healthcare workers, not to be homeless, incarcerated, drug users. We don't tend to be on the high risk of organ transplant or even some of the medical conditions. While, of course, some of us have to go through cancer and chemotherapy, it's not a big population compared with the elderly. So this, if you were just to look at it from the outside, would be exactly the wrong population to be testing for TB unless you believe that employees are still getting TB from their patients, which we're not. And we know that because we've been doing annual TB testing forever and ever. And that TB, that conversion rate was less than 1%, and that was using the skin test that had plenty of inaccuracies. So in terms of driving, okay, so I had before that these numbers here are what drove the policy that we're going to talk about. But I want to flip into how we make these diagnoses and how these numbers were generated briefly. So there are 3 tests available in the United States for tuberculosis diagnosis, latent TB in particular. So those are 2 IGRAs, interferon gamma release assays. Both are whole blood assays. The QuantiFERON Gold in tube plus which is the latest iteration. It's the 4th generation, has 4 tubes. It is an in-tube interferon gamma release assay. It's run as an ELISA on standard ELISA plates. The TB T-spot by the Oxford company is also uses the same TB antigens, the ESET6 and CFP10 in its assay. So both of these interferon gamma release assays use the same TB-specific antigens, ESET6 and CFP10. Both have a positive control and both have a negative control, and I want to talk to you about those. So they're quite similar in that way. Where they really differ is in the technique. So the TB T-spot is a phycol separation assay. It is a more complicated assay to run. It's not run by a lot of labs in the U.S. It is run primarily by their main laboratory located in Memphis, Tennessee, such that this test is drawn into, I used to call it green top in a box. You would draw a green top or 2 to have a backup tube, drop it in their FedEx labeled box, and mail it off to their lab, which used to be in Boston, but they had so many weather problems that they moved the whole thing to Memphis. Now all the tests are done there, where you have better issues with weather, but we've obviously had a lot of airplane disruptions this year, and we have them, of course, in other years. If you're flying out of Denver, a lot of plane disruptions, and the time that those tubes can be delayed can be a big problem with this test. One great thing about the TB T-spot in Oxford was that the laboratory and the personnel, not the test, but the lab and the personnel in Memphis were purchased by Quest Laboratories, which I think really adds a level of, I don't know how you say it, but public oversight into the way the tests are done and the way the results come out. And so I was very pleased with that transition. So that's the second option. The third, of course, is a TB skin test, which I show you on the crocheted doily, because this thing is over 130 years old. It served its purpose. I hope not many of you are using it anymore. In 2009, when I came on to VA, I came on from ER as the chief of Occ Health with a stipulation that we would never do this test again. And to my knowledge, we haven't. There are certain ID docs that will need to use it in certain incidences, but it is far less accurate than the IGRAs. I have a lot more experience and familiarity with QIAGEN, with the QuantiFERON test, so let me just run through this test really quickly. I don't want to bore you. I just want you to run through a couple little things you might not know. So the QuantiFERON, and as I mentioned, the T-spot as well, but there's a couple of really fabulous things about this test, I have to say. So the gray tube is the nil tube. That's nil, negative, nothing. When one's whole blood is drawn into that tube, there should be no interferon gamma release except what your body's doing in the background. If you have a little cold, you might have a little IGRA. But that's our background tube. That's the control on the test itself. If the gel breaks on the bottom, if the cap comes off, that nil tube will alert you that there's a problem with the test. The second 2 tubes there, the green and yellow, are TB antigen tubes, and these are super cool. Let me see if I have my circles. So these 3 tubes are super. So I circled the gel on the bottom there because it can break with too much vigorous shaking. So it's better to do the gentle rocking motion. But there's gel on the bottom, and then on the tubes themselves, there is a spray applicator to the TB antigens, as I mentioned, in tubes green and yellow, and then the purple tube has a phytohemagglutinin slurry, a PHA slurry, and that is the mitogen tube. So on the far left is the negative control. On the far right, the purple tube, is the positive control. The slurry that's coated on that tube, when you add whole blood and you rock the tube, is going to activate anybody with a healthy immune system's blood. And they're going to release interferon gamma at that point because there's such a slurry of chaos on that tube that one wants to see that the person's immune system is working. That's what the positive control is. It's on the patient's immune system. In the U.S., we might have severe cancer, we might have transplant, we might occasionally have HIV, but worldwide with tuberculosis, who has it? People with AIDS, people with severe malnutrition, starvation. And so brilliantly, both of these companies made sure that there was a positive control tube there so that we could make sure that the immune system was working before we generate a result, negative or positive. Now, the two tubes in the middle, the TB antigen tubes, are also coated on the sides with the TB antigen that's applied, which is why when the whole blood comes into the laboratory through phlebotomy or a lab itself, they must be shaken up and down 10 times at least. And that's because we have to activate the walls of the tubes to interact with the whole blood. The reason I spent some time on this is it's unique. We don't have other tests that basically do the assay inside of the tube. It's fascinating, it's unique, it's clever. We have a lot of information that comes out of getting the results of all four tubes, so that the gray tube, the nil, should be 0. The purple tube should be up near 10. The positive control should say, yes, I have a huge immune system response. And then those two TB antigen tubes in the middle, you can rest assured they'll be accurate. I hope that your laboratories will always report out the values of all of the tubes. The MMWR in 2010 said that the values should be reported out. Sometimes that flips. Now, why is that important? There's a graphic on this tube that's missing on the bottom. I want to run through this real quick, and I'll try to be faster on the rest of the slides so that we don't run out of time. On the bottom, the graphic that was missing when I sent these slides in, imagine a long line across the bottom, just a straight line with little vertical tick marks. Cut that line now into 10 pieces, so 0 to 10, 0 on the left, 10 on the right. That is the range of results you can get on these tubes in the QuantiFERON, 0 to 10. What is the number that someone needs to generate to have a negative QuantiFERON test? The number value in the two TB antigen tubes has to be less than 0.35. So you think about that long line across the bottom, 0 to 10, and now put a little tick mark way on the left at 0.35. And you'll see that it's very, very hard to generate a negative test result. And in fact, the FDA required that they had a 99% sensitivity, let me make sure I didn't get that backwards now, such that one would be confident that below 0.34, there's over a 99% chance that that person is TB negative. Now, what if somebody were to test 0.36, 0.4, 0.7 on one of those TB antigen tubes? What would your lab report out? They'd report out positive. But if you report out positive at 0.7 without the data being provided to the provider saying it's actually one of the tubes is negative and the other one is 0.7, that provider is denied the ability to judge that test for its accuracy. So it isn't that it's inaccurate when it's really low, it's just that our pretest probability, okay, whenever we test a hugely negative population for a very, very low incidence disease, we're going to get a lot more false positive than false negatives. That is just a mathematical construct. That's what happens. It's the negative predictive value and the positive predictive value. So it's crucial that you report out those numbers and tell people that one or the other tube was positive and that the numbers are extremely low. Because what's the likelihood that a 0.4 really represents TB versus a 0.34 or a 0.7? It still means that the likelihood of actually having TB is down in the 98% unlikely range. So just because there's a cutoff at 0.35 does not mean that somebody above that has TB. It's just an indicator that they had a little more reaction. And what would I do as an attending? I would reorder the test on a low positive. I hope I didn't just kill you all with that slide. I hope in a way it's the most interesting for you who work in the lab or work with these numbers. I know it's a big source of question. So when we switched from skin test to IGRA, I did a study with Bob's old hometown, University of Illinois, Chicago. We got nearly 30,000 IGRA tests and TST results from our healthcare worker population. We retested them all once or even twice. When we started out the study, we were using skin tests, and we had about a 30% positive rate in both of our institutions. That means that we had our cohort were testing skin test positive, maybe from the BCG. When we switched to the QuantiFERON, we cut that from 30% of our healthcare workers being positive to 3.75% being positive. And then we had this slice over here that was another 3.5% that were weakly positive, or under 1.1. The reason this is so crucial to those of us in Occ Health is that we see thousands of people a year, right? Well, if we go from having 30% of our population, of our employees, scared that they might have TB, afraid when they get a newborn baby in the house or when grandma gets sick that they're going to give this infectious disease to someone in their family, scared that they're ultimately going to die of this disease, it weighs on them. It's horrible. You know, what if you walked around thinking that you had this time bomb inside you? So switching to a test that's accurate in IGRA is so crucial because it's so much more medically accurate, especially in the face of the BCG vaccine, which is the exact same population that actually has latent TB. So if you do the skin test and you can't differentiate who actually has TB or who had the vaccine, it's essentially worthless in this day and age. But if you use an IGRA, it does not interfere with the BCG vaccine. It doesn't detect that vaccine. It only detects these TB antigens. And that little green-gray slice of the pie there, the weakly positives, that's the little area that keeps us in Occ Health in business. Because when you have a low positive, you talk to the person, you say, hey, I don't really believe it's positive. You don't have any likelihood of having TB, I'm going to send it again. And when you send it again, 86% of them revert to negative. So the weakly positive are really important to report out to your clinicians. All right, I'm going to try to move faster now. We need some water soon. All right, looking at the QuantiFERON Gold Plus, the newest test, a little study out of Stanford, my neighbors there, Niaz Benet, and out of Canada, Madhu Pai. They took 626 healthcare workers. Again, most of us don't have any risk factors for TB, but they selected ones that didn't have risk factors for TB. They unfortunately found that they had 3% positives. This is in that range that I just showed you in the pie. Wait. No, this is going to be this is the brown part of the pie, the weakly positives. So they were getting 3% with the new test versus 2% with the third generation. That is completely to be expected because there are now 2 TB antigen tubes. So if one of those 2 tubes just jumps over that 0.34 line, it'll result as quote unquote positive. And I'll explain that. So when they then took their positives and they said, we're not going to count you on the QFT Plus as positive unless both of your tubes are positive, unless there is concurrence between the 2 tubes, that dropped their TB incidence rate to 1%. So that's great. That's a way that that is not using the manufacturer's insert, but it's the way clinicians can start to look at the test to make it more accurate in this population, because we shouldn't really be using it in this population because we know we're going to get false positives. Another study out of essentially the same group did the same thing. They said they wanted to increase the specificity for low-risk healthcare workers. So if they used both tubes as concurrent positives as the way they would diagnose TB instead of just one or the other tube, that dropped their positivity rate from 3% to 1%. They did a follow-up then of 11 discordant results healthcare workers, and they found that 10 of them went right to negative, which is what I was telling you, which you would expect, and that none had progression to active TB. And I'm going to speak with your leader, Bob McGonnagle, about us publishing our data on a similar topic, which we should do on QFT+. Okay, so what we're doing then with the diagnostics and these ELISAs is moving more and more toward automation. So we used to do it manually in the lab. Then we had these little machines like we use, the Dynax DS2 and DSX. And now, as time goes on, there are other more automated platforms, including a relationship between the QIAGEN company and the Liaison machines, so that the Liaison machine Vidazorrin can run the QFT Plus test up to 200 patients per shift, which is a huge increase from our single plate or double plate per hour and a half, which then equates to about 25 patients per hour. And you're then also not wasting as much reagent as we're using in manual labs. So this automation, I think, is really cool. I just mentioned to you a relationship between QIAGEN and Vidazorrin. The automation makes things easier and faster. It makes it more accurate. And I have no dog in this race, by the way. I work for the government and for Stanford. I just want to show you things that I think are cool. So when we automate anything and we take it away from being manual, we're going to decrease the variability and increase both the efficiency and the reliability of results. So I'm a big fan of automation already. There are other relationships as well between the TCAM Fluent and the Hamilton Robotics Microlab. They are used, a lot of these are used in Europe. And I don't know if we can run this little video now. I think some of our colleagues at Blue Sky are going to run this. You've seen ELISA machines probably that probe the different tubes, and the machines will actually uncap the tubes, and it'll pipette in and out of them, and it'll spread it out in the wells. But this is the rotisserie. So I actually like this because it takes away the shaking, and I just think it's really fun to see that part of the automation is even the shaking. Now, if you are like me in Occ Health, you worry about people's wrists shaking hundreds of tubes a day. So I just thought that was a fun one. Let's move on to policy and why what you're doing in the lab is changing the face of the way medicine is handled for 20 million healthcare workers. Where is TB coming from in the U.S.? We talked about how little it is. It's in the foreign-born. It's in these couple of states. Well, when we're getting active TB, it's coming from those persons activating their latent TB. That means they weren't treated. So 80% of all active cases in the United States are reactivation TB. Those people then transmit it. That represents another 10% of the infections in the United States. Thus, TB elimination strategy has to target that 9 to 14 million population I told you about with latent tuberculosis. And how do we target it? We have to diagnose it. We have to do the tests on the right people, and then we have to treat it. Because we can treat latent TB, they'll never get active TB, and then they'll never transmit it. So finally, we started getting some movement after those of us at Occ Health were sort of kicking and screaming. And I do want to say I've got the TB spot, the Oxford people shared with me, and I don't have this slide in this talk, but they shared with me their national results that also included patient care for 2017, and 97.4% of all national TB tests that they ran on the TB spot were negative. 97.4, and that wasn't just healthcare workers, that was people where there was some sort of pre-test probability of having disease. So we were running way too many tests on the wrong people. So the American Thoracic Society, the Infectious Disease Society of America, so ATS, IDSA, the CDC, got together. These are our leading institutions. They got together to state, basically, that IGRAs are recommended over TST in nearly all settings for diagnostics in the United States. They have a terrible graphic on this that if you want an interpretation I can give you, but basically that's what it says. There are small cases where a TST could still be used. Moving on to just right before COVID-19, I was one of the authors on this paper, one of the few Occ Health people, so I couldn't fight every battle. A lot of ID people and wonderful colleagues at the CDC and the National TB Controllers Association collaborated to write the 2019 MMWR, and this is where there's a little sunshine in the upper left, where the sun finally comes out. And I will show you what this document says. The goal of the document is the prevention of active TB disease. So remember, this is driven by all of the data I already showed you. So what's in the MMWR? Just a short 2,000 words. It says test all healthcare workers at hire and on transfer. We still need to test them all and hire because that's when we can treat them and we can catch it before they activate in our hospitals and infect anybody else. The MMWR doesn't actually repeat that IGRA is preferred. I put that in there because of the 2017. That was a battle I couldn't win. They initially had TST or IGRA, but I got them to change it to IGRA or TST at least. Number 2 recommendation, test healthcare workers at exposure and post-exposure, no change there. Educate employees yearly about TB risk factors and symptoms. That's important because of number 5. If we're not going to annually test people, we need to continue to educate them about what to look out for. Number 4th recommendation is treat latent TB in healthcare workers. And number 5, the biggest change in this document is the removal of mandatory annual testing, such that the way the document actually reads is it should not be done in any population in your hospitals. The reason the MMWR was really hard to write and took us a really long time is that most of us are probably working in fancy hospitals with all sorts of automated machines and nice lighting and air exchangers and big waiting rooms and white tiled floors. But this MMWR is talking to everybody. So it's talking to our colleagues who are down on a border clinic with Mexico, with a room without any heat or air conditioning. Everybody's sitting in the waiting room all together, coughing, waiting to see their healthcare provider. They have no air filtration. They have inadequate PPE. It's also talking to jails. It's talking to a lot of different places. So you can't, they weren't going to say eliminate it in all settings because there are some settings where one should clearly continue to be tested. But in these first world hospitals, that's not the place. Not the emergency department, not pulmonary. None of those people, after decades and decades of being tested every single year, are converting to getting active TB. So just in isolated circumstances, ideally just isolated people in each hospital should be selected for annual testing. This is a document I first authored with, again, our colleagues from the National TB Controllers Association and in this case, ACOM, the American College of Occupational Environmental Medicine. So now we're getting more Health focused. This is not 2,000 words. It's a lot longer. It has these really great appendices that are hard to find. So pull up the paper and then look for the little links to the appendices because that's where a lot of the graphics are. This document operationalizes the MMWR. So it gives you the nuances of what if they had a chest x-ray 6 months ago? What if they had a chest x-ray 5 years ago? What if they declined to get treated? Like, how do we operationalize the switches that are made in the MMWR? And in particular, the recommendation, you 44% plus 14%, that we don't do annual testing on healthcare workers. Okay, this is just going to take 1 second so we can get back on time. There was a time that the CDC said you can't do a TB test if you've gotten a COVID vaccine within the last 4 weeks. That never made any sense. It was based on 1970s literature of live vaccines and their interaction with the skin test. So that's not relevant. This is not a live vaccine. The COVID vaccines are not live vaccines, and nobody does skin tests, or at least most people don't. There's no implication or indication that getting the mRNA or the J&J, AstraZeneca brands of COVID-19 vaccines are going to affect an interferon gamma release assay or even a skin test. So they walked that recommendation back at the end of August. And the reason this is so important to us in Occ Health is this rule that said you can't do a test for 4 weeks and they just had their vaccine. Here we are trying to hire people in Occ Health in a global pandemic. We're trying to hire people into our hospitals, but we have to wait 4 weeks from their vaccine. We want them to be vaccinated. But the requirement out of that MMWR is that they get tested for TB on hire. So it was causing just mayhem in the hiring world for those of us in Occ Health. Because if you followed that mandate, you delayed people getting their jobs by weeks, you delayed their hospital system from getting people onboarded. So thank goodness that just got walked back. Running real quickly through treatments, there are 4 main treatments in the U.S. right now. This is also a graphic from that JOEM article. 3 are short course. 1 is the old traditional INH. The short course on the far left is 3-HP, 3 months INH plus rifapentine. It's once a week. It's 12 doses, if you can see the little writing there. 12 doses of an antibiotic to treat for latent TB. This was first published in the New England Journal of Medicine in 2011. It showed equal efficacy with the far right there, 9 months of daily INH, 6 or 9 months, 270 doses of INH versus 12 doses of antibiotics, showed equal efficacy and a much decreased side effect profile, including no progression to hepatocellular toxicity, fulminant liver failure, and death, as does happen with 270 doses of INH, and much higher compliance. So nobody really finishes that INH course. So these 3 short courses are the ones that are recommended. Please tell people about it. Here's that New England Journal article that I mentioned, so you can refer back to those numbers if you'd like. And this is a one-page, 2-sided handout about 3-HP, the 3 months INH plus rifapentine, which is once a week. And I love this handout. It's on the NTCA website because a lot of primary care providers still don't know about this since there is so little TB. So anyone who has latent TB, I recommend you pull this off. You hand it to your primary care provider or your Occ Health and say, this is what I want. These 12 doses of antibiotics are going to eradicate my latent TB disease. And we're done. COVID-19 will cause an increase in active TB cases in the U.S. and worldwide. And this is because of decreased access to healthcare, delays in diagnosis, and delays in treatment. The most crucial step toward elimination is what you all are doing, is testing. It's getting the diagnosis quickly, but that test has to be done in the right population. We have really good tests now. They're new and improved, the QFT+, the nucleic acid amplification testing that's done more on active TB to look for resistance patterns. There are new partnerships being formed, like between QIAGEN and DiaSorin, and there are acquisitions like, oops, that's a typo on that one, sorry, Quest buying the Oxford facility in Memphis, as I mentioned, the T-Spot facility. There is improved automation that increases our consistency and accuracy of results, but we have to use these IGRAs on the right population. We can't just be out there willy-nilly doing millions and millions of negative tests. It impacts their reliability. You know what else it impacts? Our landfill. We are creating an incredible amount of carbon waste to do. If you do 4 tubes per person and you were to extrapolate that to 10 million of our healthcare workers, you're looking at 40 million more tubes thrown in landfills, plus all the lancets and the plastic baggies they go in and the plates. So we need to be stewards of our money and of our time and of our landfill and our carbon footprints. But we need to continue testing. We just need to do it on the right people. Those from the demographics who I showed you, the locations that I showed you, those with a pretest probability of having disease. And we don't have a vaccine for TB. We have one for COVID, but we don't have it for TB. So the only way that we're going to get toward elimination is by the accurate diagnosis, which then drives supportive policies. And we follow that up as practitioners with treatment that is completed such that elimination can be achieved. And I am at the end of my time, but I hope we'll have some time for questions. I want to thank you all for your time and attention today. I know it's hard to listen to webinars. I am absolutely and truly honored to be part of this. So I really thank you all very, very much.
Well, and our thanks to you, Dr. Thanassi, for a very comprehensive and rich presentation. Let me remind the audience that we will be posting all these slides and audio for your review, including many of the papers cited. You can go back and get those. And but our first question is, we've had this from several folks, and we will get this to you via our friends at QIAGEN. We want to know what is the proper citation for no longer needing to wait for a tuberculosis test if the employee received COVID vaccination within the previous 30 days. Is there a definitive source that helps people out?
Yes, I do have a slide. It was that, I don't know if we can go back. Let me see if I can go backwards in the slides. I'm going to pull it up again. It's a CDC site, and it was this paper It's vaccines and immunizations. It's the interim clinical considerations. I have the slide up right there. So interim clinical considerations, and it's the August 31st update that you need, this one.
Okay. Thank you very much.
Sure.
Now, also to get to a very interesting question here, I want to be sure to get this in, and let me remind the audience, we do still have another 14 minutes or so, so we'll get some of your questions in. But this is an interesting one. Dr. Thanassi, could it be that some people who've noticed an increase in indeterminates or an increase in invalids using the quantiferon test on the platform of DiaSorin, could those increases be at all due to COVID infection and or COVID vaccine?
So that's a great question. I just heard at this last meeting last week about the increase in indeterminates using the DiaSorin platform. I'm not familiar with exactly why that's happening. I know that your QIAGEN reps probably can address that. I think that is a topic they're talking about. I don't remember the explanation for why that was happening, but I did hear that it was an issue. So I don't know that answer. Could it be part of COVID vaccination? No, it should not be. And I talked to you about the mitogen tube there. You have a negative and a positive control on this test. So if there was so the way it works is if you get a COVID vaccine and you build an immune response to that COVID vaccine such that your body is maybe releasing a little bit more interferon gamma than it would normally be, sort of a sophisticated answer. Mm-hmm. That amount of interferon gamma is detected in that nil tube. That gray negative nil tube is a background tube. And so it's measuring how much interferon gamma that person is making at baseline. That amount of interferon gamma is then subtracted by the formulas that are in the software or by if you're doing it manually. The background interferon gamma is subtracted from the total positive result, from the result that you get in your TB antigen tubes. So if in your TB antigen tube you get a result of 1, and in your nil tube you get a result of 0.8, that there's a 0.8 microliters per mil of interferon gamma detected, the overall result will report at 0.2 and it will still be negative. So the background interferon gamma that's released is taken away. Nobody is going to be rendered immune incompetent from getting COVID vaccine. It's not going to suppress someone's immune system so that they then can't respond to the test. So there's no logical way, and this is what we argued to our colleagues at the CDC, there is no logical medical way that there could be interference between the two tests that wouldn't be detected. Yeah, thank you.
Yes, thank you. Thank you so much. And I'm sure anyone on the call can reach out as well to QIAGEN for some answers here and literature references. There's two more questions regarding something that might influence the test results or produce indeterminate results. I'll ask you to deal with both briefly. First, how is the test performing in immunosuppressed patients, number one, and then number two, the effect of age on quantiferon.
Oh, that's such a good question, and they might be a little too specific for me. Again, I work mostly with the middle ages. There's levels and degrees of immunosuppression, such that the test is black boxed to be used as an active TB diagnostic in places like Bangladesh and India. So where you've got truly immune suppressed people, they have AIDS and they are terribly malnourished and they have rampant tuberculosis. It is a black box test. What America calls immunosuppressed, like somebody's got diabetes that's managed or hemoglobin A1C of 8%, would not be considered immune suppressed, and the test would be very, very accurate in that population. Then the more severe immune suppressed in America, like the post-transplant, if you're talking about the severely immune suppressed, I don't know. I think its accuracy should still be really good because the mitogen tube will tell you if they have a strong enough immune system to mount a response. So that mitogen tube with the PHA on the sides, if you take an immune suppressed person's blood and you put that whole blood in there and you shake it up and you expose it to the PHA, it will then release interferon gamma if the immune system is strong enough to release it. And that's your indicator as to whether or not the test is going to be accurate or positive or not, accurate or not. I want to say that I just want to mention, and maybe this is too nuanced, but some of you will get this for sure, that even if the mitogen tube tests low, so that it tells you that the person is extremely immune compromised, if the TB antigen tubes are positive, one or the other, the default on the way the software is written is that the test still reports positive. So even if your mitogen tube looks like they're very immune suppressed, if you get a positive result in the TB antigen tube, it will result as positive. So they're very conservative in the reporting. So I don't know on the very extremes of immune suppressed, but for the vast majority of the population, it should be accurate.
Thank you very much. Thank you.
That helps.
Let me move along and get a few more questions in here quickly, if I may. You mentioned that when you have a very low positive result from the test, that you would recommend repeating the test. If the repeated test is still very low positive, what do you do then, Dr. Thanassi?
You know, I love that question, actually, and I provided a paper that I wrote called Negative Predictive Value of the Test or something like that to Elizabeth Jimenez at QIAGEN just this weekend, because that's exactly what we did. We went on and did the third test. You know, you're going to use your clinical judgment on your pretest probability. There are some people that sort of just jump up above that line. If they're 0.36, 0.4, 0.6, I would really look at the pretest probability. You can do best 2 out of 3, but it's not really fair to then choose the third test. I'd give you a couple different answers. 1, I'd use your pretest probability. 2, I wouldn't hurry to make a diagnosis because TB doesn't activate quickly. 3, I would look at those exact values, and I would look and see whether you're having discordant tubes. In both cases, was only 1 tube positive and 1 tube was negative. The next one I'd say is that if you do decide to treat, now that we have these new treatments, like 12 weeks of once a week antibiotic is so benign that erring on the side of treating is no longer a problem. Erring on the side of treating in the past was a huge problem. When we had positive TSTs in everybody and then we were giving them 9 months of INH and causing all sorts of complications, that was not okay. Putting somebody on 3-HP who maybe shouldn't be, that's not going to, really cause any problems. So you could also just go ahead and treat them and call it a day and say, I don't know why your test is positive. What we do know is, I don't think I can give you the numbers right here off the top of my head. But
no, that's quite all right.
Yeah, but basically use a cutoff of around 1.1. Below that, you're not going to find as much accuracy. Above it, you are. Go ahead.
Okay, very good. Now, there's one question that's come up, and I'm very interested in your reaction to this. As I mentioned at the very start, we had 2 serious infectious diseases in the title of this talk, COVID-19 and tuberculosis, and more than one very astute participant here has asked the question, in view of the rapid development of the COVID vaccine, could some of those methods and insights be used eventually to create the holy grail of a tuberculosis vaccine? What's your reaction to that?
That is wonderful. I don't know. I did see that there's a webinar coming up on, widening the reach of mRNA vaccines. Just thinking about tuberculosis itself, I don't know. I think it's brilliant and wonderful, and I'm sure someone's looking at it, and I don't have the answer for you. But wouldn't that be extraordinary if we could use this technique for all of the major scourges on the planet?
Sure.
I'd like to. If you find the answer, get back to me through Bob on that, and I'll look.
We will certainly get that to you and to everybody else for that matter. And I'm going to close very quickly with a final poll, if we can throw that up here. Yes, bring that over. Has your organization resumed testing patients and/or healthcare workers for TB? Please say yes or no. Yes, they've resumed, and then we'll close that poll and throw up another one. We have one more. Do you know what your turnaround time for TB results are at your organization? Less than 5 days, well, less than 5 days, less than 48 hours. Very good, thank you. And we'll pull that poll down, which leads me into my closing, and that begins with enormous gratitude and thank yous to Dr. Wendy Thanassi. She's given us a brilliant, brilliant presentation today that's rich in data, rich in experience, and I think we've all enjoyed it enormously. I know I have. I also want to thank QIAGEN. QIAGEN's support for this program made it possible, and it's through their work that we bring you people like Dr. Thanassi through their good offices, and like I said, I know we've enjoyed it. Finally, I also want to join Dr. Thanassi in thanking you for spending your time with us today on this webinar. We really do appreciate you taking the time. We know your schedules are enormously busy, and so you have our gratitude. And so to sum up, thanks to Dr. Wendy Thanassi, thanks to QIAGEN, and thanks to all of you. And with that, I will bring this webinar to a close.